dialing in on this gorgeous spring afternoon and for this important update and education session. In just a minute, I'm going to hand the meeting over to Ed and Gabe and Paul, who, as is frequently the case, or almost always the case, they and the team have done the work that we're going to hear the reports on, the analytics, the scenario planning, and in many instances as well, the advocacy associated with some of these multiple threats to our governmental reimbursement streams. I should note that something you all remember well, and that is our board has responsibility for the fiscal health of our organization. And given the stakes of the threats, that is the size potentially of some of these threats, we thought without creating a sense of panic that it would be useful to nonetheless keep you as up to date as possible. And in so doing, to have this interval session so we don't have to wait until the next full board meeting. We obviously will be bringing the we'll be bringing these issues to the full board with regularity from here on in. So I'd like to remind everyone that in addition to our teams dealing with this particular set of fiscal threats, we have ongoing budget planning occurring, both capital and operating budgets. We have strategic plan updating occurring as well simultaneously. And these three efforts need to be integrated so we can make the appropriate both short-term resource planning decisions and longer term as possible. Today's session, a reminder that it's for education. It's not for decision making, but hopefully we'll have plenty of time to respond to questions as you have them. I'd like to ask Tim, in his role as chair, as well as, of course, officer of the board, chair of the finance committee, if you want to add any comments, Tim, from the work that the finance committee has been doing.
Yeah, I would ask people as you're listening to this presentation to be mindful that we are likely at the end of a period of time where we believe on a long-term basis you can balance the budget by going through the financial improvement planning processes that we've had in the past. You know, we've taken close to, what, Paul, close to $200 million out of the budget here over the past two cycles. We had planned for an additional 50 million coming up this year without any of these external revenue-based interruptions that we have or significant expenditure increases, which are tied to some of these things that Gabe will talk about, Gabe and Paul and Ed. And so as we work with the budget and as the board, as we work with our strategic plan, I think we need to be just aware that we're facing a different kind of decision process than we have in the past. Paul, at our last finance meeting, as an example of this, was thankful that in the working budget, he had put a 1% increase in basically our supplies. Should tariffs actually take place, that gets blown out of the water. And so then you're not talking about a $50 million problem. You're potentially talking about twice that, maybe more, depending on what happens. And we did have a presentation from Tracy. We're doing a good job, but you know, there are no guarantees when we're reliant on international sources for a lot of this information. So as Ken said, this is educational, but I think it's also a beginning for all of us to examine our mindset as we are contemplating various scenarios and decisions going forward. So that's what we're dealing with, I think, and the Finance Committee is dealing with it like all of us. Thanks, Ken.
Okay, and for those of you who don't have gallery view, I'd like to welcome Andy and Vince And Matt, thank you, each and every one of you for joining us. So, Ed, let me turn it over to you and Gabe and Paul.
Thank you, Ken, and thanks for Tim. Thanks to joining on this session. So, really, I think, as both Ken and Tim said, think about this as the start of our conversation with the board. And what we will not do today is go through specific recommendations of changes or program changes or specifics, but really talk to you about, I guess I put it into 3 chapters. One is have Gabe Schneider give us a grounding of where we're at as of 3:06 on April 28th, with the caveat that by 4:52 on 4:28, we may be in a different spot. But I think it's important to have a kind of common set of facts. The second, and that is both on Medicare, Medicaid, and then we've added a section on tariffs that we did for the Finance Committee. The second chapter is, so what do we think the risks are of these contemplated changes at the state and federal government? And then the third chapter is, what is going to be our process over the next several months to scenario plan to deal with these changes? The only other statement I would make is, as I talk to my colleagues throughout the state and frankly some national systems, everyone is doing kind of the exact same thing, is looking at different scenarios. Places like Michigan Medicine have an added complication because they have potential changes to the research and education program as well, which add to the operational challenges. So I think the best we can do at this point is think about what our risks are, as Andrew would do, and then think about the process for pulling triggers as those risks become more clear. And then I'll add some commentary as we go along here as well. So with that, Gabe,
Great.
You are still there.
I am.
And there might be a couple of places, Gabe, maybe we pause and look for questions as well. But could you just give us a grounding of where things are at as of today?
Happy to do that. So I'm zooming in from Washington, D.C., so the heart of a lot of the issues that we're focused on these days. If we can go to the next slide, I'll just sort of give an overview of what we're going to cover today. So as Ed said, I would like to provide all of you with a bit of a grounding, sort of a common set of data points and information, talk about the overall federal landscape. We will then do a little bit deeper dive into the Medicaid and Medicare program and how they're set up and how they may be impacted. And then finally, we'll talk about the federal budget reconciliation process, which is really the focus of our efforts right now from an advocacy standpoint, because it poses the biggest risk and threat to especially Medicaid. So that's what I'd like to cover today. So the next slide, please. So really, when we look at the federal landscape, I like to group it into 2 buckets. We obviously have those actions taken by the administration, the executive actions, and we have the congressional actions that Congress is contemplating as well. On the executive side of things, there's really 3 different areas that we've been seeing have the biggest impact on healthcare. The first being executive orders. Just a week or so ago, there was a new pharmaceutical EO that came out that has the potential to impact 340B and the drug administration process. And I think the biggest takeaway on the executive order side is that it just creates a lot of uncertainty. A lot of these EOs are then challenged in court. A lot of them have administrative actions that are required to be taken as well. And so, there's a big splashy EO that comes out, and then a lot of other details that have to be figured out following that. Tariffs, we'll talk more about that in a little bit, so I'll leave that to Paul, but leave it to say that it certainly would impact future costs, especially for construction. And then finally, the actions of DOGE and the other cost savings measures that are being undertaken in the administrative level may not have a direct impact on hospitals and health systems, although we're starting to see a delay in some of the grant approval processes, but certainly can impact our partners as well. So things like we have a $2.5 million street medicine grant out there. Not sure how this will be impacted by DOGE or not, but we also know that as a subrecipient of a Cancer Institute grant, those funds are being impacted. So a lot of uncertainty that created by the executive branch actions. On the congressional side, the normal appropriations process is probably least likely to follow a traditional path, given all the other issues that Congress is working on. And so it's like earmark request, which we have put in to support our talent pipeline, very uncertain as to what the likelihood of that is. I don't know that I would assign a percentage to the likelihood of that getting done because of all the uncertainty around the federal budget process. I was just with the House Whip, Tom Emmer from Minnesota, and he was very excited that Congress passed an appropriations bill. And then he quickly said it was a year-long continuing resolution. So basically, they didn't pass anything new. They just continued funding at last year's levels. And I think that's an indication of what we're facing with appropriations. There's not a lot of appetite to do new and different things, but just continuations of what's been done before. And then lastly, on the congressional side of things, and we'll spend more time talking about this, but just the impacts that the budget reconciliation process will have on healthcare, I think are the most significant that we're facing right now. So let's talk next a little bit about Medicare and Medicaid on the next slide. So I think it's important to note, and I know many of you know this already, but that the Medicare and Medicaid programs, the payment rates in those programs are set by law. And notably, they are below the cost of providing care. So every $1 that we spend on patient care, Medicare pays us 84 cents and Medicaid pays us 88 cents on that dollar. Now that's an average across the nation, so that's not specific to Munson, but in general, that's what our reimbursement is. So as a way to compensate for these underpayments, Congress over the decades has created a system of supplemental payments. And I have those listed at the bottom of this slide, both for the Medicare and the Medicaid program. These are all programs that we benefit from that help to recoup some of that underpayment and bring us back up to a cash even basis. But essentially, this is the system of Medicare and Medicaid. It is a base rate set by law that's under the cost of providing care and a system of supplemental payments that helped raise those payments back up to help to get us closer to break even. Next slide. So in Michigan, Medicaid is an insurance program, and I think it's important to note that it's not just an insurance program for those in poverty, but it is an insurance program for women and children and seniors. It's a program that benefits 2.6 million residents. 75,000 residents in northern Michigan receive their insurance from Medicaid, so it's a very broad-based program. It's also important to note that Medicaid is not just a state program. I think sometimes we think about it as a state program, but it's jointly funded with the federal government. And in fact, the federal government pays 65% of the total overall bill, $18.5 billion in last fiscal year. Medicaid in Michigan is broken into two pots. There's the traditional Medicaid population, which the federal government matches us at Michigan at 65%. And then there's the enhanced Medicaid population, those that are covered under the Healthy Michigan Plan, where the federal government reimburses the state at 90%. So overall, the 65% federally funded program, the state funds their match with a mix of general funds and provider taxes, and that will be really important as we talk more about the risks associated with what the federal government's actions may be. Next slide. So maybe I'll pause there real quick, Ed, just in case people have any questions about sort of that level set before we jump into the budget.
Can we go back a slide, Gabe?
Yep.
So I think one of the points I would reinforce, and I think you know this as board members, is sometimes we hear from unnamed legislators that, you know, Medicaid, some stereotypes of who's on Medicaid. And I think it's important to remember, we had a press conference about this a couple of weeks ago, remember over 60% of the births in our community hospitals are moms on Medicaid. And a large portion of our residents in our long-term care facilities, not only in the Munson facilities, but on any of the facilities in our communities, are folks on Medicaid. So, you know, when you think about who is on Medicaid, it is a much broader group in our communities than people may think. And so that's part of our message when we talk about this is our friends and our neighbors and moms and dads and that are affected by this program, not some of the stereotypes that some would like to convey.
Good point. So let's turn our attention now to this process that Congress is using that will impact Medicaid funding. And I just wanted to use this slide as a way to illustrate what it is and is not, because budget reconciliation is a very unique process. It has its own set of rules that make it unique, and it is not sort of what people refer to as a traditional or typical budget process. So what is budget reconciliation? Well, it is a way in which Congress can pass legislation without it being filibustered in the Senate. So it's a way for the majority party to pass a bill with a simple majority vote, and the minority would not be able to stop that process. The other unique factor of a reconciliation bill is that the provisions in it have to only deal with spending and savings. So you cannot have any policy legislation in that type of bill. And then lastly, I think it's important to note that this is a process that is not used frequently. Only 22 bills in the last 50 years have been passed, unlike the annual appropriations process, where typically we see an appropriations bill passed every year. So that's just a bit of a level set about what reconciliation is. Next slide. So talking a little bit about the process, one big beautiful bill is what the president calls what he would like to see a budget reconciliation bill be. But what we've seen so far is that Congress has passed a budget resolution, and this is essentially the framework. It sets top line figures and numbers that will have to be hit, so target numbers, sort of identifies the overall savings that the bill is supposed to find. The second step in the process, and where we're at now, is the committees of jurisdiction, those committees in the House and the Senate that are instructed by the Congress in their resolution, get to work. And those committees that we're most interested in are the House Energy and Commerce Committee and the House Ways and Means Committee. Once those committees meet and figure out sort of the details or put the meat on the bones as to what an actual bill, the language, the text, the proposals would look like, that then goes back to the House and Senate for debate and passage. And then if there are differences between those two chambers, they would resolve those and go to the president for his signature. So the next slide, we'll talk a little bit about what we're concerned about with the House Energy and Commerce Committee. Now, many of you may have seen or heard or read about the fact that the budget framework that was passed tells the House Energy and Commerce Committee that they must find $880 billion in cuts. So here's a little math problem for you. The accounts under the Energy and Commerce's jurisdiction total around $8.7 trillion. 581 billion of those are non-Medicaid spending. So if you were to cut all the non-Medicaid spending out of their purview, 581 billion, you would still be left with 299 billion of Medicaid dollars that have to be cut. So when folks say they're not going to touch or cut Medicaid, the math just doesn't add up. There's no way to get to 880 billion without touching some of the Medicaid funding that's in the ENC's jurisdiction. And that's assuming that all 581 non-Medicaid funding is cut out completely. I don't know that that's going to be the case. And so likely the number that will be reached is somewhere between 299 and 880, which leads us to the next slide, which is the $299 billion to $880 billion problem, because ultimately the committee is going to have to come up with a series of proposals that add up to an amount that totals somewhere between 299 and 880. So what are those proposals and what are the likelihood of them getting included in a final bill? I borrowed this slide from somebody else's presentation, but it's a good illustration of what we're talking about here. Basically, Congress has an ability to really dial up or dial down the very specific proposals. So for example, site neutral for Medicare could be a low impact if it's only on the Part B drug administration services, or it could be really high impact if they choose to impose it on all hospital outpatient department services. Same with work requirements. You could have no work requirements established, or you could have them established. So it's really, you can dial it up or dial it down. Things like GME, things like the provider tax. There are various different levels at which Congress could choose to implement policies that would have significantly different impacts on Munson. I know that Paul will talk a little bit more about some of the specific proposals that are being considered and their specific impact. But this, again, just gives you a general indication that as the committee meets here, they can look at different proposals that some will have lesser of an impact than others. Next slide. So where are we at and where are we going?
Gabe, I'm sorry to interrupt.
Yeah.
One of the questions I hear sometimes in the community is, what if this committee said, we just can't, it's, you know, it's politically or operationally, we don't think we can do this. What happens?
Yeah.
And maybe the difficulty that committee is in.
So they have this framework, these instructions that were given to them. And so they don't have a lot of latitude to say, we're just not going to do it. So what they could do is they could delay implementation, although this reconciliation bill is essentially it's set to cover the next 10 years. So they could phase in these types of cuts, or they could delay implementation of these cuts for, you know, year 3 or year 4 or year 5 and sort of balloon those. They could choose to do different things like that, but they're run by the framework that Congress has already passed. So they can't choose not to do anything, but they could decide on the timing of when those cuts would take effect. So like I mentioned earlier, the Congress passed this budget resolution in April. It is now moving quickly into May, where the Energy and Commerce Committee has a markup scheduled for next week, May 7th. And I think what's interesting here is last week, if I'd been presenting on this slide, and this is to Ed's point of things changing by the minute, I would have said that there was general agreement between the House and the Senate that they would like to see the committee markups and debate and passage take place sometime in the next couple of weeks, and that a bill would get passed by both chambers sometime by Memorial Day. Well, being with the majority whip of the U.S. House today, he was very clear that the House plans to do things along this timeline, but he has no idea what the Senate's timeline might be. And so I think that's a very clear indication that we will know more on the House side, but we won't know more on the Senate side, the more deliberative body, as it's known as, for a little bit while longer. And I was with another industry lobbyist today at lunch, and his prognostication was that we wouldn't know anything until the fall, or he said we might be opening Christmas presents and still not sure what's going on with budget reconciliation. But I think all of those are a sign of the fact that these are really big, hard decisions for Congress to make, and for there's going to be a lot of lobbying around them as well. And so it's not going to be a clean, cut and dry process. It's going to get wrapped up in the next couple of weeks. So with that, I would turn it over to Paul to talk about that other issue that is impacting.
Maybe before we move on to the tariff piece, open it up for questions that anybody has on where we're at with this kind of legislative journey and insights you have. Does anybody have any questions of Gabe or things you've heard differently and want to clarify? Nick.
Some of the things that you were describing in the potential cuts or savings, one of them was adding a work requirement.
Mm-hmm.
Now, is the potential savings in that particular one due to a lack of people falling off for that requirement?
Correct. So the saving, yeah.
I was just going to say, and if there is there a number that they can extrapolate on what that might save, quote unquote?
Yes, that's a good question on the number. I think I may have seen, but yes, generally the idea is that if you impose a requirement for work, that you will have fewer people qualify. And I think that obviously is concerning for our patients, for their insurance coverage. It can also be concerning from a financial standpoint, because some of those special programs that I mentioned earlier about, you know, ways in which we help to make up that underpayment, some of those are based on the number of Medicaid patients you see. And so if we see fewer Medicaid patients because fewer are enrolled or qualify for coverage, then that could impact the viability of an entire program, an entire add-on payment. So it has potential to have bigger ramifications than just the numbers of patients covered.
Thank you.
Kathy?
Gabe, what are you hearing at the state level? What are they planning around in terms of where this money will come from to patch the holes and the gaps?
Great question, Kathy, because I think that's been part of our message at the state level too, is, hey, eyes wide open. You guys should know what the feds are doing because they might hand you a lot of cuts coming back to the state level. So I do know that, for example, House Democrats received a briefing on the potential Medicaid cuts last week. So I think that they're trying to get up to speed on what this all means. And I know that as an association and as a hospital system, we've been talking to our lawmakers as well, because if they make some of the changes that they're considering at the federal level, it could mean a $2 billion hole in the state's budget, which is not easily filled at the state level. So I think generally it's helping them get up to speed, sort of doing a similar sort of presentation like, did you know that Medicaid is funded 65% by the federal government? Just getting lawmakers at this level, giving better understanding about what the potential impact might be. But it's a good point. They absolutely need to be aware. Tim?
So Gabe, two questions. First one is the $880 billion. Is their goal $880 billion cumulative over a 10-year period or per year? And if so, when you were saying, here's the total budget for this particular committee, is that their 10-year budget or is that their annual budget? Second question, so that I don't forget, is where does Medicare Advantage fit into the Medicare pool that you showed in terms of reimbursement rates?
That's a good question. I'll defer that second question to Paul. I don't know what the rate is in Medicare Advantage. On the first question, the 880 billion is over a 10-year period. The 8.7 trillion total, funding under their purview is I believe it's under an annual basis. That's what they oversee.
My apologies, Tim. I missed that question. Can you ask that again?
My question was, when you look at the reimbursement rates for Medicare, is Medicare Advantage just plugged into that overall average, or is there a national average for Medicare Advantage programs, given that there has been, well, prior to this administration, there was talk that the goal potentially was to have everyone under Medicare Advantage and have no straight Medicare anymore. I don't know where that sits, and maybe Gabe can speak to that, but is there a difference? And then I guess related to that is, where does the Affordable Care Act fit in terms of people going to the marketplace? Is that a Medicare, Medicaid, or is it a just off to the side adjacency?
Yeah. So I think on the numbers you showed, Gabe, I think that would be traditional Medicare. And what I would say is that, what we see and what or other healthcare organizations across the country see is that on a percent reimbursement, Medicare Advantage is actually about 1% or 2% lower than traditional Medicare. And that's just because of the denials and the additional administrative burden and hurdles that you have to get over with a program like that. The ACA, that's kind of an adjacency, I would say. I don't know, Ed, if there's anything you want to add to that.
Well, I think the risk with that is, remember, that's a lot of individual coverage. And depending on the subsidies and depending on other things, I think one of the questions is going to be, will the number of individuals getting their insurance, would they be forced to drop, which would then lead to either more uninsured or more Medicaid population. So I don't know, Gabe, do you have I know there's been talk about changing the kind of requirements and the subsidies on that. I haven't seen anything specifically.
Yeah, there's the tax credits that are expiring at the end of the year. So those would be the subsidies essentially. So it's unlikely that they will be continued. So that is, I think, sort of baked into all of our assumptions that we will see some diminishing of enrollment just based on those subsidies going away. And back to your other question, Tim, I just did a quick fact check. I was wrong. So the numbers that I gave you on the 880 billion, that is over 10 years. And the number on the 8.8 trillion for the total outlays of the committee, that's also over 10 years. So that's the same period of time.
So then how does that line up with the 229 billion issue? If it doesn't, it feels like I'm in two different time zones here.
Okay, so let's ground you. So we're talking about a 10-year period. We're talking about the total allocations overseen by Energy and Commerce totaling 8.8 trillion, and the total non-Medicaid spending totaling 581 billion. And so the difference there is 299 to get to 880. That's over 10 years. So at a minimum, the Energy and Commerce Committee has to find 299 billion in Medicaid cuts over 10 years. And that's with touching all of their non-Medicaid funding. But if they decide to not cut all of the non-Medicaid funding, it's going to be north of 299. It's going to be somewhere between 299 and 880.
Okay. I think it would be helpful at some point on that slide to put those time frames.
Yep.
Because it can get lost pretty quickly that, geez, we got to find $880 billion this year for
Yep.
out of the box.
Yep.
That's a fair point, because one of the things we're going to talk about a little bit later on the impact of Munson is one of the big unknowns is it going to happen next year, or is it going to be kicked down the can and kick the can down the road and happen in 5 years? So point taken, and we'll update that slide and get it out to everybody. Dr. Schultz, you've been patient.
Has there been any specific conversations around the rural health clinic designation? I know that affects many of our outpatient clinics in the East region, and has always been a way that we've been able to provide care for that Medicaid and Medicare population, because those reimbursements were always a little bit higher with that RHC designation. Have you heard any specific talk around RHC, and will that program remain in place?
So I've not heard any specific talk around RHCs as a program that could be potentially eliminated. I would say this: I think, given the magnitude of the amount of money that Energy and Commerce is looking to save, they're going to go for the biggest ticket items first. And I haven't ranked them all, but there's a long list of all the potential things they could change, and some have a lot higher dollar figure than others. And so I haven't seen the number for rural health clinics, but I have to imagine that it's going to be smaller than changing provider payments or provider tax percentages, for example.
Ruth?
Gabe, does the 299 to 880 billion problem, is that the total problem, or does the House Ways and Means have additional cuts in mind?
So yes and no, meaning the House Ways and Means does oversee other components of healthcare funding that could negatively impact us. However, they also oversee tax policy. And so a big part of this legislation is to extend out the Trump tax cuts and expand those tax cuts. And so when they have their own number that they have to reach, Ways and Means, it is taken up. The number is met by enacting the tax cuts that they were looking to enact.
Okay, thank you.
Okay, Gabe and Paul, why don't we move on to the next topic of tariffs?
Yes, so we wanted to spend a couple minutes just kind of level setting on tariffs, and the next few slides are put together by our VP of Supply Chain, Tracy, who did a fantastic job with it. And as Laura coins, this is Tracy's tariffs. So let's go to the next slide. So again, just to level set on tariffs. So who pays the tariffs? So actually, the importer is the person who is the person who pays, or the organization that pays the tariff. It's not necessarily the exporter, it's the importer, and then the importer can choose how to deal with the exporter or pass those tariffs on to the customers. So who collects? Customs and Border Patrol are the ones who collect from our ports. And how is the tariff calculated? So the amounts are determined by the types of goods that come in, the quantity of goods, and then of course the country of origin that those goods come in from. The money goes into the general fund of the United States, and those payments can be paid either electronically or on a monthly basis. The role of the Secretary of the Treasury is charged with establishing the regulations on collections of the tariffs, and of course, the president can impose those tariffs with national security reasons. Go to the next slide. So here's just a list of some of the vendors that are at risk here that provide medical devices. And you'll see the names on here. There are going to be many of them are going to be familiar to all of us. And of course, Munson has vendor relationships with many of these vendors as well. Go to the next slide. Nope, back one more, I think. Yep. So some of the components that may be subject to the new tariffs. So, you know, these are things like our X-ray, CT tubes, pacemakers, infusion pumps. I mean, these are the things that we use on a daily basis here at Munson. So these are all at risk with the new tariffs. Go to the next slide. So maybe just, you know, what can happen, right? So there's a kind of a range of things that can happen with the potential tariffs, and that is shortages. So think back to what I mentioned, who pays? So if the importers want discounts from the exporters to help pay for some of that, the exporters could say, well, you know, we're not going to do business with you anymore, which could create shortages in our supply chain. Those could be passed through ultimately to the customer, and that is, you know, significant increases depending on what product and where that product's coming from. Price gouging, as we know with inflation, when prices go up and then when some of that pressure is relieved, prices don't always come down as a result. So that could be with us for quite a while. Counterfeit products, so we saw this through COVID. So products, similar products coming in from different areas. And then escalation in inflation. So PricewaterhouseCoopers did forecast between a 7.5% and 8% increase in the next 12 months as a result of the tariffs that we have in place today. So I'm going to stop and pause there for a second. Are there any questions on the tariffs?
So, yeah, and Paul, in a little bit, and we could have put in this, but we're going to talk about what we think the risk is for us with the tariffs.
Yeah, why don't we move to the next slide? So what I wanted to do is just provide a little context. So it was mentioned by Tim, I think early on, the last 2 years, the magnitude of financial improvement plans that we've implemented here at Munson. And so the first slide is the financial improvement plans that we had our fiscal 24. So that's our last fiscal year. And remember, we went from a negative 4.4% margin to break even. And it took over $90 million of financial improvement plans in order to do that. And some of them are listed up here on the screen. If we can go to the next slide. So this is our current year financial improvement plans. And this year, it took $93 million to close the gap to go from break even to 2.5% margin. And the 2.5% margin was the target that we had in order to help us pay for our capital plan that we have. I would say that the last two slides, so the 24 and 25 that we just looked at, they weren't just big items, they were also big and small. There were over 200 individual plans in each of those years, all the way from a cost center manager through some of the deep dives that we do every year as part of the process and coming up with an idea for an improvement, all the way up to maybe a service line, maybe it was pharmacy that had an idea of where we could create additional value. All the way up to the executive team. So things like our workforce improvement and how we're going to implement that. So these are things that, again, it was a lot of people who were involved. And I think that's one of the reasons why we've had success over the last 2 years is it was really involvement from everybody throughout the organization. Go to the next slide. So as we look forward to our upcoming 2026, so we're in the process right now of working through that, both the operating and capital budgets. Our target for next year is to maintain the 2.5% operating margin. Again, that is consistent with our capital plans. the financial improvement that will take us, that we project that it will take us, aside from what we just talked about, so the additional headwinds, the executive orders, the tariffs, those things. So aside from that, so normal business, we projected it would take about an improvement of about $45 million for us to be able to maintain our 2.5%. That included a little bit of additional room for labor pressures, as well as some other inflation. Tim had mentioned a little bit extra we put in supply chain. That also was part of that $45 million. In areas that we're putting plans around access, so patient access, referral management, length of stay, supply chain and revenue cycle improvements, things that we've worked on the last couple of years as well. What I will say, Ed will second it, Laura will also chime in on it, is that this $45 million has been harder than the other 180 million that we've gone after the last 2 years. So a lot of those improvements that we made, it was easier for those to find those. It was easier to identify barriers to implement and then implement them. As we're starting to run out of those. And so this $45 million that the team is finding now, and we believe we're going to get there, we will get there. What those leaders will tell you is this has been harder than the last 2 years.
Yep. And Paul, if I could jump in, I think one of the reasons we wanted to give this context is when we think about how we respond to these other potential changes, I would say for the most part, we've been able to make these changes kind of at an executive team level. I'm not saying they're easy. There's lots of things, but the number of board level discussions we've had, or the board level decisions we've had, have been limited. But if we think, given that we've been at this for 3 years, the things that we'll have to talk about when we start talking about the things that Gabe talked about are different types of levers. And so I just wanted to spend a little time on that context. Laura, I think you're there. We didn't plan this, but is there anything you wanted to add, just kind of the frontline work you're doing here?
Yeah, maybe just reinforce and provide a little context to the comment that Paul made about, this $45 million is harder. We've already pulled a lot of levers. When you think about all the change that we've implemented to get to that 185, that's been a lot of work and a heavy lift. And so I think the $45 million is a much smaller number than the last 2 years. Our leaders have done so much work to review in detail and try to, drive efficiencies and reduce costs. I think they're having a harder time coming up with that next 45 million because we've pulled a lot of levers already.
Ruth?
I need to understand the 45 million. What are the drivers of that? I mean, we're not increasing our margin, yet we've got a 45 million delta across the year from 25.
Yeah,
So is that inflation driven?
A lot of it's inflation driven. So when we think about our annual wage increases, just to keep up with market, what we project on pharmaceutical increases, supplies increases, and then you look at kind of what we get in it as an increase from our payers. So we think about Medicare, Medicaid, and then commercial payers. That does not keep up pace with the additional expense inflationary pressures. And so when you look at that gap, that's a good chunk of that $45 million. And then, as I kind of mentioned, we put in a little bit of additional labor pressures, as we think those are going to happen as well. And really quickly, you come up with 45 million.
Thank you.
Yeah. Andy?
Yeah, and Ruth just mentioned this, and I don't know if there's been any consideration, but you went from break even to a 2.5 positive margin, which was 95 million. If you reduce that margin to 1.25, you make up that 45 million. Has there been consideration about maybe reducing the margin at all?
It's a good question. But when we looked at all of the investments that we feel strategically that we need to make to position Munson for success, so things like the rural care transformation, the renovations that it takes for to Otsego or the ASCs or the expansion in Petoskey, when we start building that out, the minimum margin we need to be able to support that level of investment was 2.5%. And so in order to keep pace and do the strategic things that we wanted to do, that's the minimum margin that we needed to set.
Okay, Paul, why don't you?
Yeah, let's go to the next slide.
Oh, Ken, I'm sorry, I didn't mean to cut you off.
No, I was just going to ask if the 45 million is net of or inclusive of reductions in interest earnings over this period of time on the using whatever assumptions you have for the overall economy. And given past weeks, is or are those projections for interest earnings adequate?
Yeah, well, so a couple things. I would say that the interest earnings, so we're always very conservative when we build our below the line. So that's the non-operating part of our portfolios, because you have your unrealized and realized gains, and you never know how the market's going to go. So we budget that pretty conservatively, and then look at what we can control, which is our operating margin, which is a 2.5%. So Ken, to your point, when we go into our fiscal 26 planning, we'll have to look at that usually conservative stance versus what the reality of the market is to make sure that we're still have a good enough cushion there. But I think at this point, it's looking like we do.
Thank you.
Yeah, and really quick before we move on, don't want to belabor it, but I think, you know, to go back to the $180 million, because when we talk about, so when we frame up, when Gabe frames up the government, you know, the executive orders and the budget, we frame it up in terms of cuts. And a lot of times when we think about budgets in the 45 million or other, the first thing that comes to mind is cuts. And so what I just wanted to make sure we provided to this group here is that when we look back over the 2 years and everything we put into play, when we look at our net revenue in those 2 years has increased $250 million or 19%. And our expenses increased 154 million or 11%. So it has really been a good balanced approach that we've used to come up with 180 million, and also the 45 million we're going after here between additional reimbursement. So that could be volume, patient access, and then areas where we do have opportunity to cut or reduce or be more efficient on the expense side. Kathy.
Just a quick question. I wonder if, in explaining to a broader community audience what Munson is doing in terms of our past expense cuts and what we're working on currently, if you could turn that into a percentage of, let's say, budget. Is it 10%, 12%, 15% that you've cut over the last 2.5 years, or kind of including your target? I think sometimes if we start to have to talk to the broader community, when we say numbers like 185 million and 45 million, they sound like such big numbers. I wonder if people would relate to it better if we say we've trimmed our expenses by 10 to 15%, whatever that number might be.
Yeah, so if we trying to do the math here, so it's about a 12% overall improvement. So it's if we are, so our 2.5% that we target here is $38 million of operating earnings. Mm-hmm. And so if you take that over the 180 million over the last 2 years, I think it's about 12%.
Okay. All right. Thank you.
Yeah.
Okay, Paul, why don't we?
All right, let's go to the next slide. So kind of an assessment of risk from, you know, turning those potential items into an estimate at this point based on what we know. What could it mean from a dollar standpoint for Munson? We'll go to the next slide. So on the supply spend on the tariff side, this is some of the numbers that we have at annual spend for our medical supplies. So items that we have on contract, and we go through Health Trust. So we have a little bit of protection on some of these, but that only lasts so long. And also depends on if the tariffs get raised again. But there's about $110 million of annual spend. Non-contracted items, about 11 million. Those are either at risk or are getting hit now. And then some of the non-medical stuff like our laptops and other things, about $9.3 million. So if you start thinking about a 10% overall tariff, these things add up pretty quick. And those are big numbers. We go to the next slide. So here are some of the categories that Gabe talked about, and then kind of what it means for Munson. So the Medicaid provider tax, or we call it the QAP program, we get about $66 million a year in that program. And so that we're going to put a high likelihood that gets impacted through this process. And if half of it was impacted, it's about $37.3 million that could ultimately be less that Munson gets from that provider tax benefit. From a tax exempt status, so the value of our tax exemption is about $48 million, and you'll see it broken down into those categories between real property, personal property, sales tax, and tax exempt financing. What I would say is that there's really hasn't been a whole lot of movement. I haven't heard a whole lot. I don't know if Gabe has heard much on the top three. So I think those probably have a lower likelihood. Tax exempt financing has picked up a little bit of steam. Now, fortunately for us, that's the lowest of those four categories. But it is possible that our ability to go out to the market for tax exempt financing could be at risk in the future. 340B, so this is a program that we are able to obtain pharmaceuticals at reduced prices. And part of that calculation is dependent on Medicaid patient days. So there's a significant formula that goes into that. And as long as we're able to hit a certain threshold, we qualify for the 340B program, which then gives us some reductions of what we pay for those drugs. So for our system, that's about $53 million a year. So when we think about things like work requirements, which could mean less Medicaid eligible patients, which then would drive our Medicaid days down, and then it would make it harder for us to qualify. This is one we're definitely paying a lot of attention to. We think there's high risk. And so I put about $26.5 million, assuming that it has an impact on us, but it doesn't wipe us out totally from a 340B standpoint. Site neutral payments. So what this means is that in a hospital setting, we get higher payments for being in a hospital because the hospital has more overhead in general than we would if it was in, say, an ambulatory surgery center or an ambulatory setting. If that gets impacted through this process, on the outpatient surgery side alone, that's about $26 million. If we look at lab and radiology, that's about $6 million. So when we add all those categories up, Munson annually gets about $200 million of our $1.5 billion from just those categories above. And then if we put, again, the estimated risk, and a lot of this has uncertainty around it, but that could very easily be $70, $80, $90 million that eventually Munson could be impacted from. And then if we add tariffs, just a 10 to 20% potential impact, that's $10 to $20 million of additional potential headwind that we would have to navigate. And to be honest, I mean, that probably has a higher likelihood of impacting us sooner and harder than the ones above, which could be phased in over time. Any questions at this
Yeah, why don't
level?
we pause here and see if there's any questions. Some of these, so the question is, how did we come up with these likelihoods? Some of this from the AHA and the MHA. They've been helping us model this. So it's not an exact science, but I think this is would be supported, not probably, this would be supported by the MHA and AHA. The other thing I would say is, to our earlier discussion, the other uncertainty of this is timing. Do we think the likelihood of this 70 million. It's certainly not going to happen this fiscal year. So that's the other unknown we have to plan for. And to Paul's point, I think the tariffs probably is going to hit us quicker than the rest of this.
Yeah, and when I talk to my CFO colleagues in the state, you know, a size adjusted for their organizations, this is right into the realm of what they're looking at as well from a potential impact. Go to the next slide. So Munson's approach. Next slide. So as we talked about, as Gabe talked about earlier on, we won't have clarity for a little bit yet. That could be as soon as May, June-ish, but more likely later than that, possibly even longer into the next federal fiscal year as well. From a timing standpoint, it's over 10 years. But again, there's a lot of uncertainty as how this would be phased in, what would be phased in, and then, you know, for us to be able to calculate what that path would look like for Munson. Go to the next slide. So scenario planning, as Ed had mentioned, you know, over the last number of years, we really had a process where we were very transparent and engaged the organization into that work. You know, all the way from our front lines through our managers, directors, all the way to the executive team. With the magnitude of these, it's a different flavor, and so I think you know, wherever we do land and whatever levers we have to pull, those are proposals that we definitely want on board level discussion with. So those things could be changes in how we deliver our care, or how we deliver some of our support areas to support the care we provide, program reviews, scope of the services that we do provide, any changes to that, capital. So remember that 2.5% supported our capital. If we're no longer to hit the 2.5% or don't have plans for it, or there's uncertainty, one of the areas we need to look for is our capital plan and how do we maybe want to adjust that. And then potentially reductions in force, depending on how large these could be or how quick they come. You know, part of the levers we may have to pull would be a reduction in force. Go to the next slide. So some of the potential levers, these are the larger levers. So when we think about, you know, where would we look? So let's say it was 70, 80, $90 million. Where would we look? You know, the areas that we would look are in services and programs. So, you know, what services do we provide that from a financial standpoint, you know, would either have a negative contribution margin, or when we look at layering in overhead would have a negative contribution. And from those services, do any of those, you know, what would be the impact of a reduction or elimination of those services? Corporate, same thing, programs, reductions, eliminations. Do we have opportunities to outsource? Would that make sense? Would that reduce costs? Would that make us more efficient? Performance, how are we doing in some of our areas? And we can ask some of our partners like Vizient and Health Trust to assess, you know, help us assess that. Are there opportunities yet that we have not tapped into? And then again, reduction in force, that's would be on the table as well for our corporate areas. And then our reimbursement models. So, you know, we have a lot of different reimbursement models, including RHCs, critical access hospitals. We would maybe want to do another assessment to look at, are there other models that we could take advantage of? And then what would the impact of those be for Munson? But these are some of the larger levers that we would have to pull, kind of given the magnitude of some of those potential reductions we would face.
And Paul, maybe before you go on, just a couple of comments on this. So Paul and I and Laura met as late as this morning, and kind of our plan going forward to prepare for upcoming board meetings are, so Paul and Laura are reviewing programs that don't cover their costs, so that we have a good idea of which programs are not covering their costs and have to have a review. We're doing deep dives in some of the corporate services, which probably less of a board decision, more of an executive. We're looking at our reimbursement models. Where do we have critical access hospitals? Where do we have other hospitals that we need to take some look at what is the things we need to do, and then what are the things that our rural can't. So the point is, we need to do some behind the scenes work so that when we come to the board and have a discussion about potential options, we can have a debate about what that means to delivering care in our regions. And we will be doing that over the next couple of weeks so that we're prepared when we get closer to June to talk about some specific things and what impacts they may have on our communities and which ones we want to pull now and which ones we want to keep in our back pocket. Ken?
Yes, could you give us any indication at this point, Ed, as to whether or how you are thinking about the timing such that if we began taking some dramatic actions of the sort that they probably all to us now look dramatic, but if we took some of those actions sooner rather than later, do we get slightly ahead of the game? Or in fact, do the cuts occur at a future date and time in the main, so that if we take any preemptive steps, we're only going to need to take still the same amount of steps with no credit for what we have done in a preparatory way?
And I'll let Paul jump into this and Laura as well. I think there are certain, if you stay up on this page, there's certain things like that middle section we need to get on now. Because frankly, whether we need it now or in 3 years, we have to look at those. I think part of our board discussion that we need to have later, early this summer, is part of that decision, Ken, because what I worry less about is not so much about not getting credit, but these are very impactful decisions to our communities collectively, and some of which you have consequences to them. And I think we have to be thoughtful about how we do those, how we communicate those, and how we make those decisions. And you'd hate to do something too early without understanding the impact on our, I don't know if I answered your question. I would put these into 3 categories. Some things we just got to do now and we have to be aggressive because we know something's going to happen. Some we have to be ready to pull the trigger on pretty quickly. And some I think will require some thoughtful conversation among the board because they're substantive changes in how we deliver care. I don't know if that answered your question, Ken.
Yeah, no, we can't really answer the question well yet, I think. So I think your answer is a very good one. But I suspect when we look at the panoply of cuts, once they begin to become real, some of them we will get credit for by anticipating them and taking reductions immediately or as soon as we're able to do them. And others, if we take them preemptively, we might in fact be forced to, we might not get credit and have to make cuts after we've cut another 50 million out, the same amount. So, but in any case, I'm sure your team is going to be able to project where in fact we need to take action sooner rather than later, and where we can afford to try to be as thoughtful, cautious as can be before we pull a trigger.
Yeah. And I think those are discussions we'll have to have as a board because, these all, as we said earlier, these decisions will have consequences and we need to talk through those. And to the point of how quickly do we want to make them, or do we want to wait till some of these things become clear? And frankly, some of these, even if we started today, it takes some time to do because, it isn't that you just, some of these things we can do, some are going to take some, as I think about Tim's discussion at the Finance Committee, some of these are going to be redesigning models of care, which are going to need clinician input and board input, before we pull triggers. I'm not trying to obfuscate. I think
No.
all we do is
Yeah.
have data to know what our levers are, and then have a thoughtful discussion about which ones we pull when. Yep. Ruth, I see you reflecting.
Uh-oh.
Well, I guess my mind goes to the whole political scene, and I mean, it sounds like Congress could delay the impact of some of this so that it ballooned out in future years, and where there might be a different political reality. And so is there political wisdom that's starting to look at that? And then I guess that's
Yeah,
what
I mean, those are the things we're gonna have to talk about and Gabe once we know better I think there's one or two strategies that they could take. One is these things are just, you got to get these things in place so you can pass a tax cut, and you got to have some meat to it. Or the second is the political pressure that's coming on Medicaid is that the direction will be to say, yes, we're going to do it, but it doesn't go into effect for 4 years. Those have very different kind of reactions from us. I know, Gabe, what do you think about those?
Yeah, I would agree. I think the political reality is that Republicans in the House are having a hard time getting all of their members on board with strictly doing whatever it takes to cut spending to get a reconciliation bill done. We've already seen a letter put out by, I think it was 12 different moderate Republicans saying you cannot cut Medicaid or we'll vote against this bill. So I think the political realities are that it's going to be very challenging for them to come out and say on day one, we're going to cut 880 billion. Or even 299 billion. And so what I've been hearing on the Hill have been the discussions of, well, we'll phase it in or we'll delay implementation, we'll soften the blow. We don't really want to hurt providers is essentially what they're saying. And yet on the same side, they have these instructions that give them this overall amount that they have to save. So it's a little talking out of both sides of their mouth, but I do think there's some political realities that will make them try to soften the blow as much as possible.
Carl.
Well, yeah, thanks everybody for putting all this information together. In terms of the discussing cuts, I have two things. Well, in terms of discussing cuts, are there options to just essentially freeze temporarily some potential forward movement on some projects until we know more? One. And two, is there strategy, or are you already working on making sure that the staff is as informed as possible so it's not so much of a big surprise when things start to unravel, should that occur?
Let me hit the second one. Actually, Laura and I are presenting to a combined medical staff retreat on Wednesday, because that's another group we have to educate on this as we go through these changes. I think on the pause piece, Carl, I would say that's a discussion we're going to have on our major capital projects. And to what extent can we commit to some of these big projects given this uncertainty? And that's a discussion where I don't have an answer to that, but I think that's the question we'll have to take on is, all the big capital projects are there for very good reasons, but they also, once you start, then you've made that commitment. And I think that's a discussion we're going to have on what's our approach with that. I can't, Ken or Ruth, are those new hands or are those?
Oops, sorry.
Mine is a new hand, and it is to ask if there is a theoretic possibility, should the Republicans lose big time in 26, such that they lose control of both houses, is there a theoretic possibility that a new set of pieces of legislation could go in that could rescind? That's assuming the current plan is to forward adjust these cuts so that they occur later as Republicans see the unpopularity of this course of action. Then in 26, the House and Senate change. Is there a possibility that some of the damage, enough of the damage could be rescinded with new legislation? Or in fact, is that just not in any way possible given the mechanisms of government?
Good question, and it is possible, theoretically. There could be another reconciliation bill in 2026 or in 2027, and if these cuts were not to be enacted until 2028 or 2029, the Congress could get in front of those cuts, pass another bill that basically would say we're not going to make them. Now, given the overall sort of mechanisms of the process and or how one committee's jurisdiction impacts the overall budget reconciliation process, it's not quite as easy as doing that because there will be other ramifications for example, paying for tax cuts that are to be considered as part of this process as well. And it would just be dependent on how the language is structured. If you could simply roll back those cuts or not roll back because they would not have been implemented at that point, but if you could simply not enact those cuts, basically get out in front of them, or if it's tied to cost savings to offset tax cuts somewhere else, or it just depends how they write the bill. But yes, theoretically, a new Congress could come back and make changes in before these take effect.
Thank you.
Tim?
So in listening to this last set of conversation, I mean, for the last, I don't know, 15, 20 minutes, as we go through this planning, I think one of the very important things for us to do is to articulate what our assumptions are and why we're making a choice then based on those assumptions. And we've not really had to do that in a financial improvement planning process, the same way we're talking about now. And so I would hope as we discuss this at the board level and certainly at our committee level, a big chunk of the conversation will have to deal with, okay, here's all the data that Gabe or others have given us. Here's the story that articulates our assumptions on what's going to happen, when it could happen. Based on those, here are things that we would do, but more importantly, why we would do those. So it feels like a longer process, but I think it's going to be really important for people to understand that logic chain, as opposed to all the stuff that Gabe has said, which is very important. But okay, that's basic information. What do we believe? Okay, what are we going to base it on? Because in this kind of world, it is oftentimes as critical or more so to be constantly reviewing your assumption set versus just focusing on executing the plan that you put in place.
Good point.
Ruth, I'm sorry.
We've talked about possible responses that will affect our bottom line and our programs. There's a lens that I think we're going to need to look through as well. And that's who, among the people we serve, who's going to be impacted by the decisions that we make. Because like every place else, we have haves and have-nots. And my read of this is that it's the have-nots in our ambit who are going to be really impacted. And so as we contemplate decisions on behalf of our organization, I think we need to look through that lens as well.
Well said. Thank you.
And if I could just add, the sort of example we've used with lawmakers along those lines, Ruth, has been with maternity care. So if over 60% of our births in Cadillac are for moms that receive insurance through Medicaid, and we have to change the way we deliver birthing services in Cadillac. We can't just turn those 60% of those moms away. That impacts every patient that comes in the door. So it really is a broader impact than just Medicaid, the Medicaid population.
Mary.
I was going to kind of address just what Ruth and Gabe have related to, is that this is just not a particular hospital situation. It's not the physician's situation. Every person in the world is going to have medical care one way or another. And politically, it doesn't matter whether you're Republican or Democrat, whether you're old or short or fat or whatever it is. Is there a way that the whole medical problem can be addressed as this is a basic need, just like food, clothing, and shelter, that everyone needs? And if you decimate medical care, this is what the result is. And we can look at any third world country and use them as an example. Can we appeal to those legislators in a humane manner, saying that this is a real basic necessity in our lives?
I think the short answer is yes, and that's part of the story we're telling to lawmakers, that this is about their constituents. This is not about hospitals' bottom lines. This is not about those things. This is really about care for their constituents. And the more we make it about the patient, the more impactful our stories are. And so, yes, I think that really is at the heart of what we're talking with them about.
This is Dave. I can't reach my raise hand function. So I'm curious about what the rating agencies are saying about impending policy changes and budget cuts, particularly to rural hospitals. And I was recalling a statistic, something like last year, 60% of rural hospitals across the country actually lost money. And I just was wondering, what is Fitch and other rating agencies saying about prospective budget cuts on financial stability and health of?
So Paul, and I see Mary, you're on as well. So Paul, Mary, and I just met with Fitch in our annual rating call and asked that question. And again, Mary or Paul, jump in. What they would say is, yes, as an overall backdrop, but they're looking at the individual market and position of individual health systems. And what they're looking at in this context is, one, have you done what you said you're going to do historically? Two is, do you have stability in leadership to make sure you can execute it into the future? And three is, do you have a balance sheet to help you weather this storm? And that is specifically what they're looking at. And, we'll see, probably get a report back in the next couple of weeks, but, I think we're well positioned in that environment. Mary or Paul, do you want to? Mary didn't know you were going to be called on here, but.
No, go ahead, Mary.
Sure, I'm going to try and unmute here, sir. So there's a question about, say, the sector, and then there's a question about our system's rating. So Ed spoke to Fitch's perspective on our system rating, or yes, our system's rating. And that is, we are evaluated relative to the healthcare sector, what we're seeing. And what Ed said, we have a very strong balance sheet. We have said what we're going to do. Hopefully that is reflected in our rating, that they don't change our rating. They won't change our rating just because the sector has risk. When you talk about the healthcare sector, however, they are continually looking at that sector, and they could change their outlook for that sector. So right now, 2 of the 3 rating agencies, I believe, have a neutral outlook on healthcare. Could they change it and have a negative outlook on the sector? That is a possibility. Or can some sectors be looked at of all their portfolios, be looked at and maybe positive, something positive is going to come from this. But those are the two distinctions that they've made. That helps.
I
Paul,
would say we will find out very shortly.
we're going to find out.
Yeah.
Paul, why don't you go to next steps and then we can wrap up with any questions, given we're running short on time.
Yeah, I think the next slide, Ed, I think you hit this one already, which is just the executive team. We're in the process of looking through, potential impacts and then potential levers, and what options would we have, having discussions kind of internally at that executive team level, and then would bring that back as part of the budget process in June for further discussion based on what we know at the time. And I think that's the last slide, Ed.
So Ken or Tim, again, we don't have the answers today, but wanted to bring you up to speed on where we're at today. Talk about some of the scope of decisions we'll have in front of us and the process to get to those decisions over the next couple months. I don't know, Tim, anything you would like to say to wrap it up?
Buckle up. But it's very important work. I mean, some of these things, as it was questions, once you start them, it will be hard to unwind them. So we're going to have to make decisions that there's no guarantee they're going to be right, which is why, again, we need to know our story, our assumption set, and the why that we're making those decisions, so that if they do go south, we're somewhat prepared for it. More importantly, rather than going south, hopefully it'll help us to make a lot more right decisions than wrong ones. So, and I agree with both Mary and Ruth. This is not just about money. The hardest thing here is, how do we best serve our populations in this rural region, given all of the unknowns and change, that something's going to happen. It's not going to stay the same. And it's not going to go back. As some wise people said, today's rate of change is the slowest you're going to see during your lifetime, which means this is a continuing saga. But I appreciate everything everybody's done to put this information out there, and people taking time to begin to think about this, because our timeline is short. As we look at between here and July, there's not a lot of months. And for those of you who are actually working at the system, the days may seem long, but the weeks and months become very short.
Ken, any other concluding comments you'd like to make?
No, the only thing I would add, I agree with everyone's earlier comments. The only comments I would add is, as we've seen as a board, and looking at the upsides and the strategic opportunities and the new programs and the refinements and improvements, we've seen real professionalism. And now we're seeing, I think, a similar degree of professionalism on the part of your team to look at these terrible downsides. So I feel comforted by seeing the quality of the work that's been done, and knowing the characters of our colleagues that we've heard from today. The last thought I have, it's already been expressed, and I guess it's expressed best by buckle up. But I think now the full board is going to be with our committees, of course, assisting right and left. But the full board is going to now have to weigh in probably deeper and more critical ways, possibly with less time than we've ever faced, given the importance of the decision making and the speed of change, as Tim has pointed out. So, so we will need and welcome everyone's very, very best advice and our and our collective wisdom.
Well, with that, just as a reminder, this session was recorded, so we'll make sure for those that weren't able to make it, they could at least listen in. We will provide an update at the May 7th meeting if anything has changed, but you can see, and Ken, I think, give credit for the suggestion to have this. You think about trying to fit this in to a regular board meeting, it would have been a tough to fit it in with everything else. So thanks to everybody for participating, and we'll keep you in the loop as we move forward.
Thank you, Ed.
Thank you.